here for the Canadian Cancer Survivor Network. Thank you to everyone for attending our webinar series. A little background on our group. Works to connect patients, survivors, and other and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. Dr. Talhouk for her talk on endometrial cancer. Appears we have some technical difficulties. We'll get her back in right away. There we go. I do apologize once again for the technical difficulties on the part of GoToWebinar. I will just give control to Dr. Talhouk. And I apologize for anyone else who had technical difficulties on account of GoToWebinar. There she is, and just need her.
Good morning. Can you hear me?
We can hear you. So without further ado, I would like to pass it over to Dr. Talhouk for her webinar, Changing the Story, Early Detection and Prevention of Endometrial Cancer.
Good morning, everyone. It's a pleasure to be here. Thank you very much for having me. I would like to start by acknowledging that I'm speaking to you today from the traditional, ancestral, and unceded territory of the Coast Salish people. That includes the Squamish, Tsleil-Waututh, and Musqueam nations. It is really a big honor for me to be a guest on this land, also known as Vancouver. Let me start by giving a story. Last week, I heard a strange clicking sound in my car, and I, like most people, I hoped it would magically fix itself, because the thought of calling a mechanic and booking an appointment and taking time off work, none of that felt possible in the middle of the week last week. Often life crowds out the little warning signs, so the clicking became a clunk, and then soon after the car gave up completely. So we all have stories like this, not because we ignore problems, but because daily life is loud, busy, and full, and our bodies work in the same way. They whisper before they shout, but signals are faint and often inconvenient, sometimes brushed off by the very systems that are meant to help. So if we could create ways to catch those early whispers in months rather than years, we can change everything. So the outline of my talk today is to talk to you a little bit about endometrial cancer, the risk factor and symptoms associated with this disease, early detection and prevention, and the impact that that could have on patients' lives, and inequities and gaps that we currently see in care and research. And I want to talk a little bit about what my lab is doing and how you could help. So let's start. Endometrial cancer is a cancer that begins in the inner lining of the uterus, and that is the womb right here, and not to be confused with the cervix, which is here at the tip of the uterus, or the ovaries. Endometrial cancer is the most common type of uterine cancer. It represents about 90% of all types of uterine cancer, and it is the most common gynecologic cancer in Canada and in high-income countries. So in Canada, every year we have 8,500 new diagnoses and 1,600 deaths. And unlike most other cancers, the incidence and the mortality of endometrial cancer is increasing year after year. And so a recent report from StatsCan shows that from 2000 to 2018, we're nearly doubling in incidence, and a 50% increase in the number of deaths. That's very different from what we see for most other cancers. And more importantly, unlike breast cancer and cervical cancer, where there are screening programs and screening recommendations, there is nothing for endometrial cancer. So why do we see this increase of cancers? And it's primarily related to increase in risk factors and in aging population. So what are the risk factors that are associated with endometrial cancer? A higher body weight is the most important risk factor. So every 5-point increase in BMI is responsible for a 60% increase in endometrial cancer risk. So what is BMI? BMI is a simple number that compares a person's weight to their height. It gives us a rough measure of body size. It does not tell us everything about health, but it helps us researchers see trends across large groups of people. And so, not surprisingly, we see a lot of things that are also associated with high body weight being also associated with endometrial cancer risk, this being diabetes, a sedentary life, high blood pressure, unhealthy diet. But we also have other risk factors like hormonal imbalance, reproductive factors, such as early start of menstruation and later start of menopause. Polycystic ovary syndrome is also a big risk factor, as well as Lynch syndrome, which is an inherited condition. What are the impacts and outcomes on patients? So most commonly, we see this being a postmenopausal disease, with the vast majority, 85%, diagnosed after the age of 50. About 10% are diagnosed between 40 and 50 years of age, and fewer than 5% are diagnosed below the age of 40. Now, these trends are quickly changing as we are seeing an increase in the number of people who are experiencing higher body weight, sedentary lifestyles. We are seeing more and more cancers develop early on, and the numbers are quickly shifting around. The 5-year survival is very much stage dependent, with stage 1 and 2 having good survival, close to 90%, stage 3, 50%, and stage 4, dramatic drop to 15%. So what is stage? For uterine cancer, stage 1 is when the cancer is completely inside of the uterus, and in many cases, this could completely be cured by just removing the uterus via a hysterectomy. Now, as the stage goes, the cancer spreads beyond the uterus. That's how we're seeing the survival rate dramatically shift. And so how is endometrial cancer diagnosed? I'll tell you the paradox a little bit of early detection. So the first presenting symptom in most of endometrial cancer patients is abnormal uterine bleeding. However, that symptom is not specific. 1 in 3 women will experience abnormal uterine bleeding in their lifetime, especially in a period as they're approaching menopause. And so the literature tells us, and our own research tells us, that many women will not report abnormal bleeding because they don't think that it's something worth reporting, or that it's something that is of importance. They may wait for symptoms to persist before reporting it. And often what we hear from patients is that they feel often dismissed by their provider, and that's why they may not report these symptoms. On the other hand, once they've made it through the system and they've told their provider, now we're seeing the flip side of this coin, where we're seeing a lot of testing, because ultrasound does not reliably detect endometrial cancer, and often you need a referral to a gynecologist who will do an endometrial biopsy, and that procedure is fairly painful and invasive, and only less than 5% of abnormal bleeding would result in endometrial cancer. And so this is the paradox of underreporting and over-testing for this disease. So my lab recognized that the first step in detection is to recognize and seek help for symptoms of abnormal bleeding. And so we wanted to see whether or not women, as they approached menopause, were able to distinguish what is abnormal versus what is normal and recognize risk factors and symptoms. So we did this study. It was a qualitative study, and we asked women whether or not they recognized what abnormal bleeding is. So just as a way of adding the information, abnormal uterine bleeding is any postmenopausal bleeding and any changes in frequency, regularity, duration, or volume premenopause. We noticed, so here's a quote of what someone has told us. I had like 1 drop of blood. It was just minimal. It was easily ignored, but a month later, same thing, just a tiny, like, don't know if it was 2 drops, it was or less, it was very minimal. Then I Googled it and it said to see your doctor. And that's the first time I'd heard of, like that it could be a problem, really, which is really interesting because we definitely rely on women recognizing this as a problem and seeking help. Women also confused gynae cancers together. So most thought that endometrial cancer was the same thing as cervical cancer, and that they felt that they were protected by doing regular pap screening. They didn't recognize many of the risk factors, and they often over-attributed the risk to family history of cancer. So they would say something like, oh, no one in my family had this type of cancer, so I felt like I didn't need to worry about it. So here's another example from a quote of one of our participants. I usually had my pap test regularly, and I always thought that it was like my security blanket. I thought that I had all of that covered, It's not. So cervical cancer is different, of uterine cancer different than ovarian cancer, and different than, vulvar cancer, etc. With regards to seeking care, often our participants attributed abnormal bleeding to menopausal symptoms. And so they waited to see that the symptoms persisted month after month before seeking medical care. And they did not felt like they were worried about overburdening their provider. They acknowledged that their providers are very busy and that this was perhaps not something that they wanted to disturb them with. And many women also said that they felt previously dismissed, and so they didn't want to go back to their provider with more questions. So here's a quote from our participant. I'm not a doctor. I can only tell him this is what I'm having. So every time you go, they send you back. You don't want to be like a fool, keep asking the same questions. So with diagnosis, the most important thing is to seek care for symptoms. After that, an ultrasound is done, but these are often inconclusive. They give us an idea whether or not the endometrium is thickened and whether or not it needs to be investigated, but there are a lot of issues of false positives or false negatives. So really, an endometrial biopsy is the standard of care. It is invasive and painful, and often our participants described it as inhumane. And it may be also at times inconclusive on its own if they're not able to get enough material, and so it would require more testing after that as well. So here's another quote from one of our participants. "I know a biopsy is a test, but a biopsy is barbaric." So often these would be procedures that are done in the gynecologist office without anesthetics, and they're quick, but they're very, very painful. And some women have reported passing out of these procedures. A silver lining is that prevention is very effective for endometrial cancers, and there are so many different ways of preventing it. So basic surgical ways, so for example, a hysterectomy and removing the uterus would prevent it. Bariatric surgery to reduce body weight would prevent it. These seem a bit extreme, right? Like nobody wants to be doing, we don't want to do hysterectomies on everyone, but some people who are at extremely high risk, like those who have those inherited Lynch syndrome, inherited mutations, they are recommended to have hysterectomies as soon as they're done their childbearing because their risk is extremely high to get the cancer. But there is also chemopreventions, like hormone therapy is really effective. And some of the hormone therapies could be involved taking progesterone pills, or even the Mirena IUDs, the intrauterine device, which is used for contraception, could be very effective at preventing endometrial cancer. There are some studies that talk about aspirin use, some studies that talk about diabetes. Today, we also know that a lot of the obesity drugs, the GLP-1 drugs, could be very effective at reducing body weight. And could provide lasting prevention for patients at high risk of endometrial cancer. So studies have shown that even just a reduction of 1 point of BMI could result in about 10% reduction in cancer incidence. Increasing physical activity and adopting healthier lifestyle could also reduce cancer risk, even independently of losing weight. We know from several studies that up to 60% of endometrial cancers could be preventable. In Canada, 40% of those cases of endometrial cancer are linked to excess weight. Precancers can also be detected and reversed with hormone therapy in over 60% of the patients. However, we need more research to make prevention cost effective, because it's not feasible nor cost effective to implement these measures at a population scale and give this to everybody. So we need to know who is most likely to benefit from these preventions and from early detection, and direct our efforts to them. A key thing as well is that survivorship is really neglected here. We know that 5 or 10 years after diagnosis, over a quarter of survivors have been diagnosed with heart disease. So this is, again, 33% higher than in any age-matched women without cancer. And this is probably attributed to the similar risk factors that have caused the endometrial cancer to begin with, which is excess body weight. Another study showed that 5 years post-diagnosis, there was a higher risk of dying of cardiovascular disease than dying from the cancer. And then, again, this kind of tells us that we have a window of opportunity to change the life course of people that are diagnosed with this cancer. And associated comorbidities that could come in sequelae. Most of those cancers do not recur, so secondary prevention of cancer is also important, but most of them will not recur. And when they do, often the outcomes are really dismal. And so we need better understanding of why people recur and how to prevent recurrences, even though most of the patients will not experience a recurrence. A few years back in 2016, there was a priority setting exercise that looked at what are the most important unanswered questions for endometrial cancer. And these are the top 10 that came up. This was an exercise that was done with patients as well as with care providers. They talked about personalizing risk score, determining which vaginal abnormal bleeding requires a specialist to review, effective treatments, prediction of recurrence, as well as several understanding of underlying causes, time of predicting who benefits from hormone treatment to reverse precancerous lesions and early stages of cancer, and what the impact is of lifestyle changes on improving the treatment, the recurrence, and preventing the cancer. In 2024, there was a study on endometrial cancer that was done actually by a Swedish group that focused, but they also did in general. So it was kind of a report that talks about how to improve care and how to drive policy change. But they did generate an additional report, which was very interesting, looking at Canada as a case study, where they provide an overview of the burden of endometrial cancer and identify an area of improvement in care and policy response. And they've identified a few things. So first of all, they have identified, as we have in some of our studies, barriers in accessing care. So many women do not have family doctors. They do not have access to primary care providers. And there was a long delay in obtaining imaging and referrals. Furthermore, long wait times to see specialists like gynecologists and gynecologic oncologists. So for example, in the report, they highlighted that gynecologist appointments, the median wait time in Canada jumped from 3.1 weeks in 1993 to 22 weeks in 2023. And this highlights a delay in the detection process. Even just recently in British Columbia on the news, we heard that many doctors in the interior of British Columbia just quit because they are overburdened and overworked, and there just aren't enough specialists to see patients. And again, this creates a barrier to access and delays the detection process of cancers, of gynecologic cancers, and especially endometrial cancers. There are also inequities that are observed with this cancer. So endometrial cancer disproportionately impacts marginalized communities. So material deprivation, being of lower socioeconomic status, not having not having material deprivation, those people are less likely to detect cancer early. They're experiencing more delays, they're experiencing worse outcomes. Some ethnic minorities are impacted with more aggressive types of cancers, and we don't really still understand whether it's confounded with socioeconomic status or whether there are genetic variations that we need to be accounting for. The research is still not very clear on this. We also know that Indigenous populations have experienced historical traumas, systemic racism, and often will distrust the health system and may delay seeking care as well for their conditions. finally, the people that are at highest risk of endometrial cancer, those are with excess body weight. They face systematic fat bias from health provider and stigma, and that leads them to decrease self-seeking care-seeking behavior. Finally, the situation with respect to funding of research is really very, very sad for this disease. The funding definitely does not match the burden of the disease. So when we look at incidence rate of where the funding is going, the cancer of the uterus is so low compared to the other cancers. So here, brain is the top, leukemia, ovary, breast, prostate, pancreas, non-Hodgkin's lymphoma, all the other cancer, colorectal, lung, and uterus. So we are getting less than 1%, actually 0.6, half of 1% of the total research investment. When we look with respect to research funding as a function of mortality, we're the second last. So again, there is definitely not enough funding. And worse also is the fact that a lot of the funding is focused on treatment, on understanding the biology, but very little funding is going to prevention, even though a lot of research has indicated that over half of those cancers can be prevented. And so we need to really think about why that is, and why we're not funding more prevention research. Another big thing for this type of cancer is lack of policies around an initiative around this disease. So there's nothing that exists for endometrial cancer equal or comparable to the WHO's Global Breast Cancer Initiative or the Cervical Cancer Elimination Initiative. And the Canadian Strategy for Cancer Control, which was released in 2019, they released a 10-year strategy document. They do not mention endometrial cancer. And most reports that come out ignore this cancer altogether. But let me remind you here, this is the most common gynecologic malignancy. And it's the fourth most common gynecologic, fourth most common cancer impacting women. Another key point is there is no, the patient's voice is really missing in this cancer. So there is no advocacy whatsoever. Unlike for other cancers, we have, for example, Ovarian Cancer Canada, Ovarian Cancer Research Alliance in the US. There's nothing like that for endometrial cancer. I want to say not only in Canada, but I want to say worldwide, the voices of the patients is missing. And advocacy organizations play a really important role in lobbying for funding and creating momentum in research by, coalescing patients' voices, researchers, and clinical needs together to find cures and to prevent this disease. So, typically where we've seen patient advocacy succeed in engaging, increasing public awareness, and in lobbying for federal funding. For example, Ovarian Cancer Canada was successful in obtaining $10 million in research funds from the federal government a few years ago. Nothing like that for endometrial cancer. And these organizations help lobby for policy change. Again, we need the patients' voices. My lab is focused on the uterine health and cancer prevention, early detection. So we have worked on molecular classification in both endometrial and ovarian cancer, and now we're completely focused on risk modeling to direct screening and prevention, targeting prevention studies for patients who are most likely to benefit from it, adopting minimally invasive early detection, so that we could encourage people to seek care without overburdening our health systems, and this will help improve screening and surveillance, as well as guide prevention. We're also working on cancer detection using artificial intelligence and ultrasounds imaging. So we have a few studies that I just want to highlight quickly. One which just recently completed, it's called the RESTORE study. It's a study that's designed to investigate the feasibility and acceptability of tailored screening and risk-reducing interventions in population at high risk for endometrial cancer. And we're hoping that the outcome of this study will help us design a larger Canada-wide study to evaluate the effectiveness of risk-reducing strategy. So now the study has completed. We've submitted a manuscript and we've already started designing the next phase, and we're starting to apply for funding. We basically recruited 713 participants. We've had them answer some risk questionnaires, and after we've had an introductory call with our research team, we discussed the study procedures, which primarily involved collection of a vaginal swab, and then a short hormonal intervention, and then the collection of another vaginal swab. And then after that, we directed them to a program. It's a lifestyle program called the Small Steps for Big Changes, traditionally designed to be a diabetes prevention lifestyle program, but we worked with the researchers at the UBC Okanagan campus to revamp this program to make it appropriate for endometrial cancer lifestyle prevention. And we've had our first results of feasibility study, which we're starting to publish now, and we're really hoping to really roll this out Canada-wide. Another study that we're looking at is the detector study. It's a non-invasive self-sampling to detect endometrial cancer in women with abnormal bleeding. The outcome of the study will help us determine who needs an endometrial biopsy and who can forego it. So we've funding for the study already, and we've started recruiting for it. And this is going to be key because this could alleviate the burden on gynecologists and help triage who needs a referral and who could be managed perhaps by their primary physicians. And a third study that we are doing is with Lynch syndrome patients. So as I mentioned previously, Lynch syndrome is an inherited condition that increases an individual's risk of developing certain cancers. It's associated with more than tenfold increase in the risk of endometrial cancer, and often hysterectomy is recommended as a prevention. However, we want to see whether a simple vaginal swab could help indicate the onset of cancer to help women who have Lynch syndrome and are of childbearing age monitor their uterine health while they're maybe still trying to get pregnant or are completing their family planning without having to undergo annual biopsies and ultrasound imaging, which could take up a lot of time and effort from the patients. So finally, I just want to say, we need your help. We need patients. We need advocates. We need family members of loved ones who have suffered from endometrial cancer. We need to really raise awareness and help guide the research agenda for this. So I just want to invite everybody who is interested to join our community advisory group. We have a group that's very active in helping us define our research and what is most important for patients. So please do try to reach out for us if you have capacity and are willing to help. We'd love to hear from you. And with this, I'll end my presentation and leave some time for questions. Thank you.
Thank you very much, Dr. Talhouk, for that presentation. Very eye-opening, and also as a cancer that hasn't gotten as much limelight as you said than other ones. So it's very interesting to hear the details about this cancer. Anyone who has a question, please don't hesitate to put it into the GoToWebinar tab. A question that I kind of want to ask you is that about the relation to diabetes. Uh, Research and diabetes kind of ideas in helping treat endometrial cancer. And I was wondering if you could talk a little bit more about, just aside just from lifestyle, or just if it's just simply lifestyle that kind of links these two together.
Yeah, so we're not really sure exactly. A lot of studies show that diabetes or patients who are diabetic have increased risk beyond just their obesity or increased body weight. So there may be aspects that are that increase, like maybe insulin resistance, or additional aspects that could be problematic for diabetics that also increase the risk. We just don't have enough data to know the interplay between these risk factors just yet. But those are all very interesting research directions to follow. We just don't know. But again, in today's world where we take into account like the diabetes, we have so many potential treatments, we have so many prevention for diabetes. Like, why not capitalize on this and take advantage of it to prevent this cancer?
Mm-hmm. Margaret asked a very important question. Is there currently any other test to replace a biopsy? I can attest to the fact that they are extremely painful.
Unfortunately, there aren't, and we're working really hard on that. And again, if Margaret wants to join us, please do. We need your voice so that we could get more funding, so that we could continue our research in this space.
Sorry, I have given Agnes I've given Agnes the microphone. Agnes, if you have your question and you're able to, go ahead and please say it right now. And once again, if you can just type your questions to GoToWebinar tab on the side, they'd be more than happy to answer that. Sorry, Agnes, I do not believe that we have your, can hear you, unfortunately. But if I would go to Lisa's question, are there ways to make the biopsy more comfortable? Any learnings from other disease sites?
So, I mean, unfortunately, it just seems like a lot of women's investigative procedures do not care so much, or do not account for making things a little bit more comfortable for women. It just seems like this is almost like a pattern that we see, where yes, menstrual pain is painful, live with it. Childbirth is painful, live with it. Endometrial biopsies are painful, just 10 seconds, deal with it. That just seems to be the attitude in general, which is very frustrating. Being a woman myself, facing these issues myself, at times, you would think that nobody would ever fill your tooth cavity without giving you anesthetics. But why do they think that doing an endometrial biopsy is okay without anesthetics or without proper pain relief? And I think that those are some of the ideas that we need patients' voices in order to amplify the importance and the need to do this.
And knowing just looking at cancers over the time that we have here at CTSN, the fact that women's pain gets ignored comes up time and time again. And also it is something that slowly is getting a national recognition to it. But as kind of a side note of that, have you seen any best practices when it comes to just pain, aside from the obvious one of obviously take it seriously, but has there been any best practices to kind of get through the doctors to say that, you know, just because pain is that's because you're feeling pain doesn't mean that I shouldn't be taking you seriously?
Yeah, I mean, we see this a lot everywhere. I think I was speaking recently to a gynecologist who mentioned to me that they're now treating this as a trauma, so that's kind of like trauma informed. So they're letting patients know before coming to their appointment that they're going to be doing this, that it will be painful, so that they're prepared mentally for it. They're giving them some potential pain meds like ibuprofen or Tylenol. But you know, again, these are like, is that enough? I personally don't think it is. I think, you know, if there is a way to do this in a minimally invasive way, especially given the low yield, well, I mean, the low yield is not because the biopsy doesn't detect it. It's just because most of the cases of postmenopausal bleeding, abnormal bleeding, are not cancer. So we need a better way. And again, I think the reason why the biopsy is done so universally is not because, you know, they love to torture women. Not really. It's mostly because there is no better way. There are no better tools to rule out cancer, and we definitely don't want to miss any cancer. So that's why the biopsy is given universally. I think, you know, some gynecologists will tell you that maybe pain relief is not, or maybe the pain relief maybe not not as effective, but the time that it takes for it to take effect could potentially, or that the procedure is so short and quick that maybe it's just does not justify. Although now with like insertions of IUDs, for example, a lot of physicians are giving, you know, certain like the laughing gas or various measures to make the experience a little bit more palatable for patients. So I think things like that should be adopted, but really we're putting a lot of focus on minimally invasive detections to forego the need for a biopsy in the majority of cases.
Excellent. Monica has a question, and I really hope I do not mispronounce this, because she says, everything you have talked about has happened to me. Are you doing any research on leiomyosarcoma in your study?
Not specifically, but we would love to hear a little bit more about your experience, and if there is a need, we will definitely try to think of that. So please join our group.
Excellent. And for everyone who is wondering, we will be emailing everyone a copy of the video and a copy of the slides to your email. So if you want to talk more with Dr. Talhouk, you'll be able to, and so you can get involved in the programs. I think that's all the questions we can do for today. So Dr. Talhouk, thank you so much for this very eye-opening presentation. And it appears that a couple people are interested in what you're doing. So I'm really happy to pass those along. And once again, thank you everyone for your questions. It was a very informative webinar. So thank you so much for that.
Thank you very much for the opportunity, and I look forward to working together with everyone so that we could raise the voices of patients who have had these experiences. Thank you.
Mm-hmm. And now, once again, a reminder that this is one in a series of webinars that we are holding during the rest of the winter, all the way up until almost Christmas. We have information on our website about the next one. If you didn't get your e-blast from our mailing list, there will be an e-blast coming out shortly. But if you are not subscribed to our e-blast, please head over to our website and subscribe to our newsletter. And I would like to once again also thank all of our sponsors for the webinar series. Without them, we cannot continue our educational endeavors as we've been doing. And if you'd like to check out our other webinars, please head over to our website, survivornet.ca, or head on over to our YouTube channel, Canadian Cancer Survivor Network. And so with that, thank you everyone for a lovely presentation, and I will see you on the next one.